So this is an injury which involves the meniscosynovial attachment or the meniscotibial ligament of the posterior horn of the medial meniscus. The term was first coined by Michael Strobel from Germany. What is important to understand is that it's an under-recognized entity because it is located in the blind spot of the posterior medial corner, so we are not able to identify it unless we look for it closely through the AM and the AL portals which are placed anteriorly. And what is the significance? It has been shown that if the ramp is neglected or untreated, there is a high risk of failure following ACL reconstruction, leading to increased anterior tibial translation and rotation issues. So therefore, it's very important to recognize this to try and rectify the sagittal and the rotatory laxity, thereby reducing the risk of ACL graft failure. The prevalence, as we understand it better and we look for it, we have noted that the prevalence could be as high as 40%. Clinically, the patient would present with some sort of a valgus internal rotation and axial loading mechanism. Tenderness would be on the posterior medial joint line. The standard meniscal test may be positive. What is important and one of the key features is that there would be a high-grade pivot. So we need to suspect a ramp in that situation. However, the sensitivity and the specificity of the above tests need to be evaluated. As far as MRI goes, it was very beautifully highlighted in the first talk that what you see key features is the posterior medial bruise and also a high signal intensity. So if you see the posterior medial corner, this is what an intact ramp area would look like vis-a-vis the arthroscopy image on the right, which shows a meniscocapsular separation. So we need to pass the scope in the Gilchrist, using the Gilchrist maneuver and look for it, probe it to make sure that we are not missing out on this problem. There is a dedicated classification which divides it into 5 types. There are 3 options for managing this entity. One is to leave alone, just do some sort of a stimulation without needing to repair it or to repair it. So what are the decision-making factors? It depends on the depth of the tear, whether it's partial or full, the extent of the ramp lesion, and the degree of instability on probing. So generally, the partial tears, which are type 1 and 2 as per that classification, are stable and can be left alone as they do not contribute to increase AM translation or rotation. And this is the evidence supporting that management, wherein stable lesions did not kind of lead to any subsequent deterioration of the joint or the ligament reconstruction. The second option is to just abrade it or refine it. The idea is to initiate a fibrovascular response. This is once again reserved for partial and stable tears to ensure that it subsequently heals up. And again, studies have shown that this method is equally effective and you don't necessarily need to surgically repair the low grade or the stable lesions. So when it comes to repair, it is generally reserved for types 3 to 5, which are unstable, as you can see in these diagrammatic representations. And there are 2 main techniques. One is the inside out, using the instrument through the posterior medial portal, and the other is the all inside, which we are all familiar with. And the idea when you do the all inside is that you extend the knee as you pass the all inside sutures so that you can reduce the ramp. So this is a video highlighting the inside out repair. In the posterior medial corner, it's helpful to use a cannula to try and allow suture management. There are dedicated lassos, although you can use your shoulder 25-degree lasso, and you can pass it first through the capsular area and then go on to the posterior half of the meniscus, as seen here, using a low profile suture like a 0 or a 2-0 fiber wire in this situation. And again, you tie the knots on the capsular side so they are not onto the articular cartilage. So the easy trick is to start from the midline and go towards the periphery, so you don't have an obstruction of vision. And what we are trying to ensure here, in the interest of time, I'm just going to fast forward it. This is what we want to ensure, that there is a nice watertight repair. The rehab is pretty much similar to a meniscal tear, depending on the extent of the ramp lesion, but sometimes you have to do either partial or non-weight bearing. And the return to full activities should be determined as per your ACL reconstruction protocol, because most of these ramps are seen in association with ACL or PCL tears. So again, repairing these ramps has shown very high level of benefit and evidence that it reduces the laxity and subsequent risk to failure. It also improves the functional scores. And this systematic review published a couple of years ago showed that really you can improve various return to activity scores by addressing the lamp in conjunction with the ligament reconstruction. So in summary, when dealing with ligament injuries or meniscal injuries, it's important to have a high index of suspicion, look for the hidden areas, arthroscopic probing and visualization of the posterior medial compartment in modern day management is extremely important and necessary. The size, character, and the stability determines the treatment option for the ramp lesion. Stable lesions can be left alone. You need to repair the unstable lesions because they have a high risk of failure of your ligament reconstruction. And repair with either techniques, the inside out or the all inside, has shown good clinical outcomes. Thank you.